Hello, I'm Michael Failings, Professor of Neurosurgery at the University of Toronto, and I'm pleased to have been asked to contribute a chapter to the Yeoman's textbook on the assessment and treatment of metastatic spinal lesions. I wish to acknowledge my co-author, Dr. Anik Nader, my research fellow, and I also wish to acknowledge Dr. Nader Hijrati, who also provided assistance with the preparation of this talk. Let's consider this case, and this I think will frame the discussion. And the management of patients with spinal metastasis requires a great deal of judgment and knowledge, but certainly neurosurgeons and spine surgeons are increasingly encountering these patients, and there is a substantial role for surgical management. So here's a 46-year-old woman with metastatic breast cancer. So she has a metastasis involving the subaxial cervical spine at the C5, C6 levels. There's focal kyphosis. There's significant epidural cord compression, and she's presenting with mechanical neck pain, gait instability, bilateral arm pain. But importantly, she has no other metastases. So what should we do, and what are the outcomes? So the learning objectives of this chapter will be to provide an overview of metastatic spine disease with a focus on metastatic epidural spinal cord compression. We'll talk about the epidemiology and definitions. We'll discuss clinical presentation, related pathophysiology, and the most relevant investigations. And then we'll talk about the diverse challenges related to management, and then highlighting the role of a multidisciplinary team, as well as clinical tools, including prognostic models, to provide a management framework. And then we'll discuss various therapeutic options. And so the outline for the chapter in the textbook covers these different topics, looking at the epidemiology, looking at the management, and we'll introduce the clinical prognostic models and the management framework. We'll introduce the concepts of performance, status, and frailty. And we'll discuss various therapeutic options, including surgical options and non-operative options. And then we'll make some concluding remarks. So the spine is a very common source of metastatic spine disease, and excluding lymph nodes, metastases most frequently involve the liver, then the lungs, and then third is the skeletal system. And spine is the number one source of metastases in the skeletal system. And patients with metastatic spine cancer can exist in about 10% of patients with metastatic cancer. Prostate, breast, lung, kidney, and thyroid cancers are the ones most typically associated with metastatic spinal disease. And the big three are breast, prostate, and lung cancer. And these collectively account for about 80% of metastatic spine disease. Spinal metastases most commonly involve the thoracic spine. The next most frequent is the lumbosacral spine, followed by the cervical spine. Here's the definition of metastatic epidural spinal cord compression, shown schematically on the right in this picture. And by definition, there are two key features. So there needs to be imaging evidence of compression of the dural sac with compression of the spinal cord and or cauda equina. And there needs to be at least one of the following clinical features: focal axial or radicular pain, motor or sensory disturbance, as well as autonomic dysfunction, including bladder, bowel, and other forms of dysfunction. So again, metastatic epidural spine cancer can affect up to 10% of patients with cancer. Mostly comes from lung, breast, prostate, and kidney. The median age at diagnosis is between 40 to 65 years of age. And the median survival is around 7 months. So this is a very sobering diagnosis, but there is a lot of heterogeneity in patient presentation and patient outcome. And so it's very important to have a framework to evaluate these patients. If left untreated, patients will have debilitating pain and irreversible neurological deficits. And this will result in shortened survival and worsened quality of life. This study by Patchell and colleagues, published in The Lancet in 2005, was a game changer in the management of patients with metastatic epidural spine cancer. Prior to the Patchell trial, surgery was disfavored in these patients, and patients generally underwent external beam radiation treatment. What the Patchell randomized trial conclusively showed was that, in general, patients with metastatic epidural spinal cancer are best treated by surgical decompression, reconstruction of the spine, followed by external beam radiation. And this was superior to external beam radiation alone. And this was shown by improved neurological status, as shown by increased rates of ambulation. And there was a reduction in the use of narcotics and corticosteroids. And there was a trend for patients to have a longer survival. A few years later, our group in the North American AO Spine Network sought to replicate Patchell's findings, but to take this a step further and to focus on health-related quality of life. In this multi-center prospective study, we found that the median survival, as shown in this Kaplan-Meier curve, was about 7.7 months. We found that about 6% of patients died within about 30 days after surgery. About 30% of patients died within about 3 months after surgery. And then there were a number of outliers with longer survival. A surgical treatment is not without complications. We found a complication rate of just under 30%. And this included infections as the most common complication, about 10% of patients. And so attention to the use of wound vancomycin, as well as more minimally invasive techniques, is helpful in reducing these complication rates. But despite these issues, there was significant improvement post-operatively in all key health-related outcomes. So, for example, there was improved neurological function, as shown by the INSCI examination. There was improvement in pain, as shown by the brief pain inventory. And there was also improvements in the EQ-5D Osteoarthritis Disability Index and the SF-36. And importantly, there were a number of key domains in the SF-36 that showed significant improvement postoperatively. These included social functioning, emotional well-being, general health, physical functioning, as well as the psychological aspects, as shown by the emotional subdomains of the SF-36. So in conclusion, based on this study, which was an extension of Patchell's landmark study in The Lancet, we found that surgical intervention as a complementary adjunct to medical treatment provides immediate and sustained improvement in pain, neurological, functional, and health-related quality of life outcomes with acceptable risks in patients with focal symptomatic epidural spinal cord compression. So the management of metastatic epidural spinal cord compression is focused on preservation, enhancement of quality of life via symptom palliation, with a focus at looking at the elements of pain, reduction in neurological deficits, and the treatment of mechanical spinal instability. And the three main components of treatment include corticosteroids, radiation therapy, and surgery. Now, there are a number of clinical tools which are quite helpful in the assessment of these patients. This is a skeletal oncology research group, nomogram, and this uses a number of fairly straightforward metrics. So, for example, looking at the hemoglobin level, the white blood cell count, the age, the presence or absence of metastases, the performance scale, and then you can connect the dots, and then you can get an assessment of survival probability. Our group came up with an even simpler approach, and this is now available as a web calculator, and we looked at survival and quality of life outcomes after surgery. And here we found that the independent predictors for improved outcomes or higher score in the SF-36 physical component scores, the presence of breast, prostate, or thyroid tumors is the primary tumor, female sex, likely because of the association with breast cancer, the absence of organ metastases, and the absence of radiation treatment prior to metastatic epidural spinal cord compression interventions. And this is the web calculator at spinemet.com. Another useful decision framework is the NOMS framework, which includes neurology, the oncologic assessment, mechanical instability, and systemic disease. So the NOMS framework. So one looks at the degree of epidural cord compression and the severity of the myelopathy. So patients who have a low-grade epidural compression without myelopathy are in the top portion of this table. And then patients with higher grade cord compression and myelopathy are lower down. And then you can classify this based on whether these patients are sensitive or relatively resistant to radiation treatment. The important caveat being is that stereotactic radiation treatment has rendered most tumors sensitive to radiation, provided there's adequate epidural clearance. One then needs to have an assessment of mechanical instability, and I'll go over the SINS classification system in a moment. Then one needs to have an assessment of the systemic disease, including the patient's relative frailty or lack thereof, and the presence or absence of systemic metastases. And I'll go over this framework in the context of the patient presentation that I showed at the outset toward the end of this talk. This is the Bilski grade that is used to assess the degree of cord compression. And so these are the various subtypes of Bilski 1 with varying degrees of dural compression, but no significant cord compression. And then Bilski grades 2 and 3 have moderate to severe degrees of epidural cord compression. And this is the spinal instability neoplastic score, or SINS score. And the key domains to look at are the spinal location, in particular, whether it's a junctional level or an area of the mobile spine. Is this a semi-rigid area, such as the mid-thoracic spine, or a rigid area, such as the pelvis or sacrum? The presence of mechanical pain is a key indicator of instability. And then lytic bony lesions place the patients at higher risk for instability, as does the presence of subluxation, translation, or de novo deformity. The extent of vertebral body collapse, in particular greater than 50% collapse, is a significant risk factor, as is the bilateral involvement of the spinal elements. And then based on this, you come up with a calculation. So 6 points or less, the patient is stable. The patient is clearly unstable with a score of 13 or greater. And then there's a gray area in indeterminate region 7 to 12, where a lot of judgment is required. In addition, to try to get a sense of the patient's relative degree of frailty and their performance status, it's useful to use the Karnofsky performance status. And the key cut point is at a score of 70, which is where the patient is able to care for themselves, although they are having a difficulty. And then below this level, the patients have significant dependency. So certainly patients with a performance level of 70 or above are considered to be excellent candidates for surgery. And then patients who are more impaired require a greater degree of judgment and individualization of decision-making. And then in addition, it can be helpful to look at frailty. And so the metastatic spinal tumor frailty index has been suggested, looking at the presence or absence of anemia, chronic lung disease, coagulopathy, electrolyte disturbances, renal failure, malnutrition, whether the case is being done emergently or electively, and if the patient is requiring more extensive surgical approach, just an anterior or combined surgical approach, and if there are significant pulmonary or circulatory disorders. Now, in addition to surgery, it's important for the surgeon to have an assessment of whether adjunctive treatments are available. And this is where multidisciplinary conferencing of a patient with consultation can be helpful. Now, in patients who have asymptomatic spinal metastases, there is judgment that's required, and occasionally these patients are picked up on screening imaging. These patients can, however, develop various medical issues, including hypercalcemia, what are referred to as skeletal-related events, or SREs. These include pathologic vertebral compression fractures, and this can then go on to metastatic epidural spinal cord compression. So these patients will require a careful observation, and certainly the presence of hypercalcemia needs to be watched and treated. And there are options that are available with the use of osteoclast inhibitors, and denosumab has had a particular beneficial role. This is a rank L inhibitor, and in addition, intravenous bisphosphonates can be helpful. And so this is where a consultation with the medical oncologist can be very helpful in the multidisciplinary management of these complex patients. Now, chronic pain occurs in about a third of patients suffering from advanced cancer, and certainly involvement of the skeletal components of the body, and particularly the spine, can result in significant pain. And so having an approach to pain management is also very helpful. And here, radiation treatment, as well as the selective use of transpedicular bone augmentation techniques, including vertebroplasty or kyphoplasty for painful compression fractures, can be helpful adjuncts to surgical management. So for uncomplicated symptomatic spinal metastases, radiation treatment is still the mainstay of treatment, and this usually will involve external beam radiation treatment unless the patient has what was previously felt to be a relatively radio-resistant tumor, such as renal cell cancer, in which high-dose stereotactic radiation treatment is an excellent option. And on this slide, we see the cone of treatment that would be involved in conventional external beam radiation treatment, and this can be applied much more selectively with a stereotactic radiation treatment. The important point here, though, with stereotactic radiation treatment is there needs to be epidural clearance to allow safe irradiation of the tissues around the dural tube. Now, again, these are the two principal options that are available. So conventional external beam radiation treatment and stereotactic radiosurgery. Now, the choice of radiotherapeutic modality will depend on a number of factors. And the chief one, though, will be the degree of sensitivity of the tumor to radiation treatment. So stereotactic radiosurgery has a particularly valuable role in trying to enhance the long-term disease-free state. So this could be applied in patients who have a generally excellent prognosis where you're trying to avoid local recurrence. And in addition, this can be used quite effectively in patients with relatively radio-resistant tumors, such as renal cell cancer. And this image shows a contour planning map for a spinal radiosurgery in a patient done in Toronto by my colleague Arjun Sehgal. And there is excellent evidence to support the use of stereotactic radiosurgery, and there are a variety of techniques to apply this, including the cyberknife technique. And these papers illustrate the improved local control that can be achieved with stereotactic radiosurgery. And so there's a relative therapeutic benefit for the use of stereotactic radiation treatment for patients where one anticipates a long survival. So, for example, patients with oligometastatic breast cancer. The stereotactic radiosurgery does appear to enhance local control after surgical decompression. And this is a paper by Ilya Laufer and Mark Bilski is showing relatively improved outcomes with stereotactic radiation after surgical decompression. There are also minimally invasive percutaneous vertebral augmentation procedures, and these include vertebroplasty or a kyphoplasty. And this is safe and effective in the treatment of pathologic vertebral compression fractures and the treatment of uncomplicated painful spinal metastases. And these are some of the different techniques that can be applied. One of the relative potential benefits of a kyphoplasty relates to the restoration of vertebral body height, and there may be better control of the location of the bone cement when the posterior cortex of the vertebral body is compromised. But again, this is very operator dependent. And this is a comparative study looking at the roles of vertebroplasty in kyphoplasty in patients with vertebral body fractures which were painful. And you'll see that myeloma represents a very important subset of these patients, although as seen in this a paper out of MD Anderson, there were a number of other lesions that were also treated. This is the landmark CAFE study published in Lancet Oncology by Berenson and colleagues, which quite clearly showed the beneficial role of balloon kyphoplasty over non-surgical fracture management for the patients with painful vertebral body compression fractures. And this is one of the figures out of their paper, and this is showing NRS pain scores, and it's showing a dramatic reduction in the NRS pain scores with balloon kyphoplasty compared to controls. So there are a number of medical options, including non-steroidal anti-inflammatories, corticosteroids, opioids, and bisphosphonates. And steroids are very commonly used at presentation, in particular in patients with metastatic epidural spinal cord compression. Now, again, coming back to the Patchell trial, and this again was a landmark study showing significantly improved outcomes with a combined surgical treatment and radiation therapy. And certainly the goals of surgery are to achieve adequate spinal decompression and a durable spinal stabilization through the least invasive procedure to maintain quality of life. And so whether one does a very aggressive en bloc resection or more minimally invasive separation surgery plus or minus stabilization will really depend on the patient's presentation. So let's come back to this patient that I presented at the outset. It's a patient I managed, a 46-year-old female with breast cancer, and she has oligometastatic disease, no other metastases apart from this region in the cervical spine. She has significant mechanical neck pain as well as bilateral radicular arm pain. She has an unstable gait, and she's clearly myelopathic with a high grade of epidural cord compression, as shown on this mid-sagittal image, as well as on the corresponding axial image. So let's apply a few of the selected clinical tools in this patient. So this is a applying data from our paper. This is the World Neurosurgery paper that comprised part of Anik Nader's PhD thesis. And here we found various independent predictors of longer survival. And the patient that I've referred to in our case vignette has a tick point next to each of these. So she has an excellent performance status. She has breast cancer. She's a woman. She has no organ metastases, and she is naive for previous radiation treatment. So this is the SINS score. So let's look at this. So in terms of location, this is mid-cervical spine. So this is a mobile area of the cervical spine. So 2 points. She has significant pain. So that's 3 points. There's a lytic metastasis, 2 points. There is some de novo deformity with focal kyphosis, 2 points. There's no collapse, but more than 50% of the vertebral body is involved, 1 point. And there is bilateral posterolateral involvement of the pedicles and facets, 3 points. So this person has a SINS score of 13 and is clearly unstable. Let's look at the NOMS decision framework. So in terms of neurology, the patient clearly has a significant myelopathy with a high grade of cord compression, and I would have rated this as between a Bilski 2 and 3. The tumor is relatively sensitive to radiation treatment. The patient clearly has an unstable cervical spine. And so according to this algorithm, the best option is surgical stabilization, followed by external beam radiation treatment. Let's look further. The patient does well in the Karnofsky performance status, and she has a mild frailty based on the fact that it's likely that she'll require fairly extensive surgery to manage this. So all in all, it would appear that this patient is best managed with a surgical approach followed by external beam radiation. And in this paper, in decision-making in the surgical treatment of cervical spine metastases in the mid-cervical spine, we concluded that anterior approaches should be done in the majority of cases, and a combined anterior-posterior approach is favored for multi-level disease, circumferential tumor involvement, and/or poor bone quality. And certainly this patient has multi-level disease and circumferential tumor involvement. And so this is how we managed her. So this is with a combined anterior-posterior approach, 2-level corpectomy, anterior reconstruction with cage, bone cement, and a plate. And then we flipped her over and did a posterior cervical decompression with multi-level lateral mass fixation. And the outcome was excellent. The patient is fully independent. She's pain-free, neurologically intact, and thankfully disease-free at 4-year follow-up. So what are the take-home messages? The treatment of metastatic spine disease is focused on the enhancement of quality of life, and we're really looking at reduction in pain and improvement in neurological function. In general, metastatic epidural spinal cord compression is best treated with a combination of surgery and external beam radiation therapy. Stereotactic radiation therapy has opened the door to the radiotherapeutic treatment of tumors previously felt to be radioinsensitive, and a classic example of this is renal cell cancer. Vertebroplasty and kyphoplasty are important, minimally invasive options for neoplastic compression fractures, and the classic example is compression fracture related to myeloma. And on that note, we'd like to thank you for your attention to this lecture, and I hope that the messages I've conveyed will assist you in your management of these challenging patients.